figured roughly on the number of people who are coming, and the fellows eat a lot, but they can't eat all the food you leave behind. So, interesting topic, something I've always wondered if there's anything real about this. We'll hear in just a little bit. So Paul McBride's going to do multiple drug intolerance syndrome. Drew, does it need to be quite this dark in the room?
If you turn on a little bit, the strobe light comes on in the back.
Strobe? Cool.
Disco. Party.
Good morning. I have to echo Lynn's comments that this is a really frustrating situation that we face sort of on a regular basis. And I divided this into two parts. First is, does this disease or entity really exist, which is sort of a point of contention. And then the second one is, if it does exist, there are sort of some postulated mechanisms on how this can occur. So I just have to find, since it's so dark, I can't even find the buttons.
Try putting a little light on, see what happens.
Oh, no, I got it.
Strobe effect.
If you look at the definition of multiple drug intolerance syndrome, it's usually intolerant to 3 or 4 unrelated medications. And adverse drug reactions and drug intolerances are more accurate because most of these people aren't truly allergic. And if you go back and challenge them, most of them don't even have reactions to the drugs. So it includes IgE-mediated allergy, IgG, T-cell, and other adverse reactions to drugs. And then the WAO recommended dividing these reactions into 2 types. First is immediate, which is less than an hour, pretty much IgE-based. And then the other is delayed reactions occurring after an hour. And it contains all the other types of immune reactions, but typically not IgE-mediated. So if you look at the significance, most patients with any record of a drug reaction have one implicated medicine, and the treatment is obviously just don't use that drug, and there's not really much of a concern. But when you get these patients in your office and they come in and they say, I'm allergic to every known class of antibiotics, and I have an infection, and I've had reactions to every one, this sort of gets us frustrated. And if you look at the utilization of medication, these people come in and tell you they're allergic to penicillins and cephalosporins, and they get vancomycin. And then nobody knows what to do with them other than that. So it makes the cost of therapy quite a bit more expensive. And then the patients get sort of uncomfortable with us suggesting things because they've had so many bad reactions in the past. They don't want new drugs. So they basically come in, treat me, what can I use? I don't want you to use anything. So you get put in a sort of in a quandary right when you first meet these people. So if you look at the people that have really bad quote-unquote MDIS, and the people that have the largest number of adverse drug reactions, those are the people that you really want to study, because the thought is, if we can figure them out and figure out what's going on with those people, then maybe it'll give us a better handle on this entity itself. So if the mechanisms of sensitization in these people can be understood, maybe we can prevent new reactions. And in this case, reactions are, again, a broad term, not allergic, in general, just intolerances, allergies, sort of every kind of immune response that we see. Now, Macy and Ho studied basically 2.4 million people in Kaiser, California, and they had to meet 2 criteria. They had to be in the Kaiser system for at least 11 months out of the year 2009, and they had to have at least 1 healthcare visit with all the identifying data, including drug allergies. And the interesting thing is this study was done totally retrospective through an electronic medical record. So there's some concerns that they may have missed things with this, but basically they think that the important things are going to be added to the record. And then all the patients had their allergies reevaluated on every visit with anybody in the healthcare system, pharmacist, nurse practitioner, physician. And they divided the drug allergy entries into 2 categories. There's 1 for antibiotics, and there's sort of 2 for other. And they included in the other category topical antibiotics, ophthalmic antibiotics, antiviral, antihelminth, and antiprotozoan drugs. We're all considered in the other category because their mechanism of exposure and utilization is sort of different. So they took...
What about all other kinds of drugs?
They put them in the other category. So basically everything else was in other, including nonsteroidals and ACE inhibitors, which proved to be the most common. So if you look at the antibiotics, they divided them into 10 classes. Penicillins, sulfonamides, macrolides, cephalosporins, tetracyclines, quinolones, nitrofurantoin, clindamycin, metronidazole, and then others, so for the orphan drugs. And then the second class was for the antibiotics. It was ACE inhibitors, number one, and then antidepressants, antiepileptics, contrast materials, steroids, lipid regulators, local anesthetics, narcotics, NSAIDs, and all the other antihypertensives except ACE inhibitors, and other non-antibiotic chemicals, along with proteins and stimulants. So they sort of divided them up into this two broad categories. And then what they did is they classified all the patients that they could get. They took the number of drug allergy entries for each patient, and you can only get one entry per class. So if you have 6 different antibiotics in the penicillin class, that would only count as one class of allergy. And then the number of drug classes was determined, and to be considered for this study, they had to have at least 3 or more unrelated drug class allergies. And then they split these people into 2 categories of MDIS. One is severe, which is 4 or more different drug class allergies or 10 or more unique medication entries in the drug allergy field. So they evaluate severity into pretty much the usual things: maculopapular rashes, urticaria, and then they had the 3 codes that were the most concerning for them were Stevens-Johnson syndrome, Stevens-Johnson toxic epidermal necrolysis overlap, then toxic epidermal necrolysis, and anaphylaxis they sort of handled differently through the study because they felt that was truly IgE mediated as opposed to the others. So if you look at the medication class allergies by sex, females outnumber males in this disease often 2 or 3 to 1, which is what makes it not seem like it's a typical random distribution. So in this group from Kaiser, there were 1.3 million females and basically 1.1 million males. And if you look at the patients who were allergic to penicillin, it was 9.5% for females and 5.9% for males. And then if you go down the list, it's from more allergies to lower. Sulfonamides were second, macrolides third, cephalosporins fourth, and then down to metronidazole. Women basically are 2 or 3 times the prevalence of men in almost every category, except for the penicillins, which is the only one that was really close to the same. Then they took, of these people, there were 480,000 basically people in this Kaiser group that reported any kind of allergies whatsoever. And of those 478,000, 318,000 had only one allergy, so they were dropped from the study because they didn't meet the criteria of having this MDIS syndrome. Most of the allergies were to antibiotics, and if you take of that 318,000, 229,000 were just antibiotics, and the other 169,000 had non-antibiotic allergies. And then there were 79,000 patients that had allergies in both categories. And again, females had higher allergy prevalence for all 23 medication classes, at least twice the levels of men in almost every category.
Paul, are you going to get to the definition of allergy here? I mean, is this just
No,
accepted?
unfortunately, the definition of allergy doesn't enter into this syndrome very much because it was initially described as the multiple drug allergy syndrome, and then as there's more and more literature, people want to drop the term allergy altogether, and they just basically call it intolerances, because less than a very small fraction of these people truly are allergic. So that's
the crucial thing is here, what are the symptoms? And I guess in EMR recording you lose that.
Well, the EMR recordings, again, most of these are maculopapular rashes, and that's why they went after the more aggressive or dangerous diagnoses. They went back and tried to recreate that, and they were unable to recreate most of this. So they just basically, it's reported as an allergy, and they took it at face value. But they'll comment very quickly that very few of these people are truly allergic at all, let alone to multiple drug allergy or multiple drugs. So they just sort of made it the intolerance syndrome because they included IgE, IgG, T cell, any other kind of reaction that these people could have, and they're just all lumped together, and that's how they split it out.
So basically, any adverse reaction the patient reported of any kind.
Correct. And then they went through and they tried to figure out which category of drug it was in to see if they could meet the 3 different drug categories, because up to that point it was just an adverse drug reaction until they lumped them together. So there were 57,000 people who had no drug allergies prior to joining Kaiser who developed at least one new allergy during the remainder of that year. Of that group, 1,700 had their first healthcare visit that year, mostly because of their allergic reaction. And then the people who had one allergy report had higher population incidence rates for all other medication classes that they're utilizing. And this is another one of the characteristics of this group. They're usually on polypharmacy. They're not usually on a single drug or 2 drugs. They're on 5 or 6 drugs. Females, again, higher than males in every category except ACE inhibitors. And if you look at new allergies through the year 2009, females had a higher new allergy incidence versus men for every medication except for ACE inhibitors, lipid drugs, antihypertensives, antiepileptics, and corticosteroids. So this was new onset allergy during the year 2009 as the group they chose to study. If you look at the patients who don't have any allergy history during that year, it was the same incidence rates for males and females to develop an allergy if they didn't have any prior to entering this study. And if you look at the different drugs, again, antihypertensives, antiepileptics, steroids, lipid drugs, they're the same between men and women if they had no prior history of allergy prior to enrolling in the study. So if you look at the demographics, you have severe MDIS, which are usually people that have more than 4 drug class allergies, versus moderate, which is 2 to 3, and then the last column is anybody in the plan that described any allergies at all. So if you look at female patients, of the severe MDIS patients, there were a total of 537 who met that criteria. Moderate was 49,000, and a total of people in the allergy positive history group was 478,000. So of the group that were severe, 509 of the 537 were female. 41,000 had moderate disease, and it was 325,000 that had any kind of allergy whatsoever. So the age in these severe patients was 68.3, plus or minus 13 years. The moderate was 62.3, and everybody else with allergies, the statistics were 52 plus or minus 20. The body mass index was considerably higher in the severe MDS group, 29.7 and 29.3 versus for normal, which plan that did not have allergies, the number was 26. So people with allergies were higher in general. The number of patients who died during the year 2010, which is sort of an interesting statistic, 3.5% of these severe MDS people died versus 2.3% in the moderate and only 1.1% overall. Psych evaluations were at 47% of the severe patients, 38% of the moderate patients, and 31% of allergy patients in general. Allergies were declared, and 52.5% had seen an allergy, had been to an allergist for evaluation in that year. 28% of the moderate had been evaluated, and only 17% of people with regular allergies had actually seen an allergist. And if you look at people with chronic urticaria, 33 of the severe MDIS group, or 6.1%, had that, 2.3% of the moderate group, and then patients who described a history of allergy, it was 1.6%. So these people are sort of at the top of every statistic when it comes to drug utilization, drug reactions, and number of medicines involved. So,
were the causes of death related to the MDIS?
They didn't stratify that out. It was just a statistic that they looked at. There was a significant increase in people in this category that had just died versus the other groups.
Again, severe there is defined as 4 or more classes or 10.
Correct.
Yeah, not severe reaction.
Correct. It's just severe MDIS is more than 4 different disease categories versus antibiotic and medication categories.
Did they go and look at those 200 and some allergy consults and see, try to dissect that?
Actually, the whole thing was done through the electronic record, and they could have done that, but I don't think they did. I think, well, these are the allergists, so they probably did half of them themselves, the 2 guys who did this study. So if you look at the demographics of these really severe people, which are the ones we don't want to see because we have to try and sort this out, 1.1% of these severe MDIS patients comprise basically 0.1% of all the total patients with MDIS. 97% had both antibiotic and non-antibiotic allergies. Severe patients were mostly female, 94.8%, and only 51% of the population of this 2.6 million was only 51% female. So there's a significant increase in the number of females in this severe group. They're usually heavier and older than the average plan members, and basically they've mostly seen allergy and psychiatry compared to the other people that were studied.
But when you look at females versus males, females are more likely to be on medication than males, and more likely to have healthcare visits.
Correct.
So did they look at that? You said that population-based incidence was still higher for females.
Pretty much in every category, it's always higher in females, but there wasn't really a lot of comments about going back into it at that level to say, what do these women have? If you look at the most common diagnoses that they carry, it's the same things you see general internal medicine for. And one of the real strengths of this study is that this study population is equivalent to 1% of the United States population. So you don't get many studies that have that kind of volume that you can sort of get these statistics out. So if you look at the healthcare utilization of these patients, if you look at the severe MDIS patients, again, it's 530 out of 478,000 people. Total prescriptions, the severe group had 40 during the year, the moderate group had 26, and the regular patients had 16. If you look at total number of antibiotics, it was 1 versus 0.6 versus 0.4. Narcotics, every group, the p-value is less than 0.01. For antidepressants, new antibiotics, new other drugs, non-antibiotics, total visits, outpatient visits, emergency room visits, every hospitalization days, x-rays, every one of these variables just says that these are high utilizers and basically highly into the system.
The curious thing is if they're reactive to every drug known to mankind, how they get more prescriptions.
That is a very ironic twist to this whole thing. And a lot of their hospitalizations end up being because of adverse reactions to drugs. And they go into the hospital, they get more drugs. And then there's one theory that sort of makes the most sense, and everybody's sort of gravitating toward that mechanism so far. If you look at their most top 10, David Letterman says the top 20, if you look at what these people are seen for, it's just the same as everybody else. It's hypertension, vision changes, GERD, stigmatisms, elevated lipids, pains, chest pains. So there's not really any clear difference in their histories as to what they're in the doctor's office for. The only difference is what happens after they get out of the doctor's office to all the medicines that we give them.
Anxiety is way down, though.
Yeah, but this is, again, it's number 20 on their list, but it's overwhelmingly represented in these severe patients. So that number comes back up as you start to stratify them. So if you look at the really severe patients that Kaiser saw, there were 18. 2 of them were coded as Stevens-Johnson, actually had toxic epidermal necrolysis. I'm not sure that's a better answer either way, but that's what they had. And of the 16 patients that were thought to have anaphylaxis, 1 was xylocaine, 1 was Keflex, and the other 14 really didn't have anaphylaxis. They had urticaria with or without angioedema. And if you look at this group, there's a significant number that have chronic urticaria that are in this group, and they kept being labeled as allergies to new drugs. And when they actually went through their history, a lot of them, it's chronic urticaria as their underlying diagnosis. So if you review of this population, Kaiser pretty much, the authors say the strengths of their study is that this represents the demographics of the United States because it's such a large group. One of the drawbacks they felt to their study was that it was analyzed completely via an electronic record. So if people didn't enter the data, there's no way they could go back and retrieve it. And what their comments were when they got a list is they think that mild and moderate drug reactions may or may not get listed in the EMR, but the severe ones will for sure be listed in the EMR. And then one of the nice things about the electronic medical record is that when they list it as a severe adverse reaction, essentially 100% of those people will never use that drug again. So once you put it in this, it's never a mistake that they get fluconazole a second time or any of these other drugs. Female patients, more allergies in general, and they predominate in both the moderate and severe groups. And what their comments are is the most common drug allergies, quote unquote, that are reported are antibiotics, but as this cohort of patients ages, they think that what they're going to start seeing is more reactions to the non-antibiotic group, which is the antihypertensives, the lipid modulating drugs, the diuretics. And they say as the study patients age that they're going to switch away from the predominant antibiotic reaction. So the major weaknesses of this study is that it can only be stuff from the medical record. And if you look at hospitalized patients, this is a whole different beast. Over 65 years old, there's specific predictors of what's going to cause an adverse reaction. The first is 4 comorbid conditions. So whether it's cancer, congestive heart failure, renal failure, liver disease, hypertension, if you have more than 4 comorbid conditions, your incidence of having an adverse drug reaction is about 50-fold increased. Using 5 or more medications during the admission and having any history of a previous adverse drug reaction is a risk factor for any further adverse drug reactions. So I think we see that, but I didn't know if we ever knew that that was statistically significant. So if you look at the psychometric characteristics of these patients, they evaluated these severe patients with at least 3 drug class allergies and no IgE for any of them. They found that they had significant higher anxiety levels, they had higher grades of depression, and they had higher grades of alexithymia, which I had to look up. Does anybody know what that is?
What? Sounds bad.
Alexithymia means these patients can't acknowledge or even describe their emotional state. They're just people that are just unable to describe anything. And they all describe a decreased quality of life, which wasn't surprising if you're allergic to that many things and in the hospital. Then there was autologous serum tests in these people. And Acero, 2003, found that 18 of 20 individuals that he saw with severe MDIS had basically a positive autologous serum test. Of these, 90% were female. The mean age was 37. All had reactions to at least 2 unrelated drug classes. Most of them had chronic urticaria if you took a careful history. And they were all classified as either moderate to severe MDIS. And only 2 patients in this group had any IgE-based disease at all. And everything else was thought to be T-cell mediated or unknown mechanism. If you challenge these people, and this is basically the gold standard for this history because there's no test that really can help us. Shavino did 1,808 challenges in 480 patients and found in every one of them, except for about 12% that they could tolerate the drug they said they're allergic to. They're 84% female, they're between 40 and 60. They had at least 3 unrelated medical allergies between the years of 2000 and 2005, and only 12% of the challenges were positive. In the other group, 87%, they were able to either take the medicine that they thought they were allergic to, or an acceptable alternative was identified on the first try, so they didn't go any further. And another study by Renham in 2010, he did 23 patients with 15 challenges per patient, and the only thing positive in that group were NSAIDs. Everything else, all the drug challenges were negative. So that's the only thing that they felt was truly a positive in that patient group. And their conclusion was, although this is accepted as a valid diagnosis, these people are actually quite rare. They're truly allergic to more than one drug class.
What were the positive reactions?
The positive reactions in the NSAID groups, they had upper airway symptoms and one had asthma. There was no anaphylactic reaction or angioedema. So they were all pretty mild reactions.
These are still Kaiser patients?
Still Kaiser patients. There's no other study with this volume. And these guys, he really thinks that this is sort of not really a disease. I think Macy's pretty convinced that this is mostly psychogenic. But there's a few people that sort of drift through that actually have true disease.
So these other 2 people are also at Kaiser, just independent of that first big
No,
study?
the challenge studies are from outside of Kaiser. These are people, Shavino was done in Italy and Renam was done in Spain. So these are outside sort of verifying the Kaiser data. So when you do again, the only thing that was positive in one guy's study was NSAIDs, and in the other guy's study, only 12% of these patients had a positive reaction to anything.
And back to slide or so, lidocaine. And I still, after all the years I've been in business, I've never seen anybody allergic to a local anesthetic, no matter what their history. You had one there where they actually had a positive challenge. Did they describe that?
The positive challenge is they had one anaphylaxis to xylocaine, actually. And I agree with you, I've only seen it once in 25 years, so I don't know how real it is. But they actually had one patient anaphylaxis that they were able to prove it was xylocaine. And of the other 17 people, they had no ability to prove anything on the rest of the group. So in the Kaiser data, it was just one out of all the people they studied. So again, although people say they have this disease or this diagnosis, it's hard to pin it down when you really have that. Now, if you look at children, most of these happen in older adults and most of them are female. So if you look at kids, Park did a study in Canada where they had data on 97 children with 2 or more drug allergies, and they found that only 1 out of 97 truly had an allergic reaction to the drug they were supposed to have. And in Kaiser's data, only 1.4% of the moderate and 0.2% of the severe patients were less than 18 years of age. So again, it's older women that are overweight and are on lots of medications with lots of comorbidities is the group that fits this disease category. Now, there's a list of all the drugs that they tested, and these are the strengths. And I found so many different studies that tell us, I figured I'd just give you this in case you want to ever test any of these drugs. But after you read through this literature, if you test anything past penicillins, everybody else says it's sort of a waste of time to test most of these other things. But this is actually the study doses that they use to study these patients.
You have the non-cataract version of that?
I think you have to enlarge it. I wanted to put it all on one piece of paper. So now, you treat these people. Avoidance is the safest and convenient, most conventional. But basically, when you have patients that say they're on all these different drugs, you can't really stop everything. So what they recommend is, unless they've had Stevens-Johnson or TEN, that you re-challenge these people. And that's the only way to prove anything in this disease is with a challenge. And then you have to be real leery if they give a history of Stevens-Johnson or TEN, any kind of desquamating skin disease. The recommendation is you just don't challenge them no matter what their history is. So now, if you believe that this entity truly exists, which I think Macy's trying to make a convincing argument that it doesn't exist in very many people, there's some interesting mechanisms that have been postulated, and the one that's the most appealing is this pharmacologic interaction with MHC and T-cell receptors directly. So these are pretty complicated reactions. Usually the molecules involved are less than 1,000 Daltons, and we're all trained that they're too small to be immunogenic. So they can either become immunogenic by, number one, binding covalently to a larger protein. Number two, they can covalently bond to other proteins, but they can bind directly to the T-cell receptor or the MHC molecule through van der Waals forces, electrostatic forces, or hydrogen bonds. And this drug binding that they've been able to see on mass spectrometry is actually very similar to the way molecules bind into MHC receptors. It's the same receptor binding characteristics. So if you look at this, under certain circumstances, this is a very labile interaction of a small drug with a T-cell receptor or an MHC molecule, and stimulation only occurs under certain circumstances. First, the drug involved has to have a certain affinity for the particular T-cell receptor. Second is there's a supplementing interaction of the T-cell receptor with an MHC molecule which takes place, and this usually is in the form of another drug in the system or an infection at the same time. And the third is that T-cell has to be ready to react to a minor signal, because if it doesn't, then there's not going to be enough evolution of the signal to cause a reaction. And this is what they refer to as the pharmacologic interaction with immune receptors. So the cells that react are what's called pre-activated T cells, and these are both memory and effector cells, and they react to drugs directly. They don't have to go through any processing because they have receptors that actually see the drug molecule. These bonds result in isolated T cell responses, more so than just going through the normal immune sequencing to form an allergic reaction. So it's not an immune response to the drug, but it's actually a stimulation of a pre-activated T cell by a fluke in the structure of the drug, in addition to the T cell receptor or the MHC receptor, which allows this interaction to occur. And often it only occurs in the setting of significant immune stimulation. So you have to have a viral infection or something else going on, like a previous adverse drug reaction, which is actually the most common variable that they see, in order for these pieces to all interact and give you this adverse drug reaction itself. So you have to have so many variables aligning for these reactions to occur that's probably the reason that skin testing and in vitro testing and challenge testing are negative, because we're doing this in isolation. It's not during a previous drug reaction or during a viral illness. We wait till these people are healthy, we bring them into the office, we test them, then we challenge them, and then it's negative, and we think, oh, this is all craziness. But it's just because we're not recreating the circumstances of the initial event. So if the viral infection or previous reactivity to another drug is not there, these unstimulated T cells aren't able to react to these small binding forces and activate their T cell receptors and their MHC interactions because the cells are more in a resting state. So if you look at this, this pretty much adds to the confusion and misinterpretations of these people that we just think that don't have any reactions because they're just crazy, or at least maybe that's my own opinion of this group. But, it's hard to believe that they're allergic to all these things when we can't prove any of them under direct challenge.
Has any of this been demonstrated in the laboratory?
Any of which?
Any of the reactions with T cells or T cells?
Yeah, they can actually show these reactions in the laboratory, and it's actually quite unique. So that's why this theory of this pharmacologic interaction with immune receptors is actually the mechanism that they think is probably what's going on.
So credible immunologists actually think this is real? Or
In
this is mostly
a
theory?
small percent of people. Yeah, I think they think that about 1 or 2% of these people it's actually a real phenomenon, and then the other 98% is probably not.
You'd have to think that these events somehow uniquely occur in a demographic of older, obese women uniquely as well.
Now that was the part that no one ever addressed in any of these papers. They all said that this is the group that has it, but they never postulated why older, overweight females would be selectively able to activate these receptors and cause these adverse reactions. And whether they're just in general more reactive, that's one of the thoughts, but there's really no compelling data that says why should women be the predominant reactors here. It's just in every adverse reaction to drugs, women are 2 or 3 to 1 over men in almost every category. And I didn't realize it was that high a number. I thought they were higher, but I didn't know how high. So the question is, what's the general stimulation of the immune system and how does this reaction occur? Well, if you look at EBV, CMV, and other herpes viruses and HIV, there's significant increased incidence of adverse drug reactions in patients who have those diseases. And there's pretty good data that these viral infections just grossly stimulate the entire immune system at pretty much every level. And that HIV actually increases the frequency of severe drug reactions and increases in Stevens-Johnson and TEN. There's a significant increase in HIV patients versus the general population. So when you have one of these viruses, you can measure increased cytokine levels in serum and tissues. These expanded T-cell clones, you can measure them in the blood. The stimulation profile is very similar to what you see in drug-induced hypersensitivity syndrome and DRESS. And there's preliminary data that these drug hypersensitivity reactions seen in MDIS patients are actually very similar to this. And this early switch from one antibiotic to another in these patients is really what causes this pattern to occur, is that you've got the lymphocytes all stirred up from the previous drug reaction, and then they're already primed up to react to the new drug, and then this process just sort of takes on a life of its own. So the second drug, if you look at how these reactions occur, once you have this adverse reaction, you put them on another drug because the patients still are sick, quote unquote, and then the second drug can exacerbate the first reaction, which just gives you more skin symptoms or more liver changes or a temperature, or it can actually present with new symptoms, which is what prompts us as clinicians to say, oh, here's a new allergy to this new drug. So the first drug is giving a macular papular rash, then you start a new drug, they have urticaria. So all of a sudden, oh, we have a new allergy. And these flare-ups are usually seen when a patient is already having a reaction. And it's almost always a skin reaction, an exanthem. And then we treat them with another antibiotic, and then they have a new reaction. So this list just propagates very quickly. And the new reactions occur much too fast for primary sensitization to occur. It's usually within 1 or 2 days. So either you have to postulate they've had this drug before and they don't remember the reaction, or something else is going on. And then most of the time, both drugs are stopped. Now their list includes 2 more drugs that they're allergic to, and they never get worked up from that time forward. We just keep isolating them down to more and more expensive drugs. So there's 3 possibilities. Either the patients are allergic to the first drug, and the second drug is irrelevant. They're allergic to both drugs, or they're not allergic to either one, and this reaction is something else totally different. So if you look at the testing, we provoke people with these drugs after there's negative tests. But the provocation studies are negative as well, because you don't have all of the series of events lined up to give you this increased sensitization of their T cells to allow this strange reaction to occur. So the question is, what are the factors that determine the difference between sensitive to one drug, sensitive to 2 drugs, and why does a delayed hypersensitivity reaction, why does that promote a second drug to react in the same patient? And we usually see this classically with the EBV infections and ampicillin or amoxicillin. As they come in with their rash, they have mono, you tell them they're not really allergic, come back in 6 months, we'll test you to penicillins, and you find out that they're negative. But this is the only reaction that we've sort of acknowledged through history that requires both the viral infection and the drug. And that's sort of the prototypical drug hypersensitivity reaction under infectious circumstances. So these flare-up reactions are not really well understood, but it's very apparent that you have to have multiple things happening at the same time. The first is that T cells have to be reactive. They have to be pre-activated. So a resting T cell is not going to have a strong enough stimulus from one of these van der Waals forces or these non-covalent bond forces to actually stimulate. The second is there has to be a pre-existing drug T cell receptor affinity to efficiently activate these T cells. So unless there's a T cell receptor that actually sees this drug in a context that's significant enough, there's not going to be enough of a reaction for the drug to stimulate the T cell. So since activation of these T cells by the drug receptor complex occurs way faster than what would be considered a normal sensitization, the thoughts are that these T cells are able to actively expand and react without going through normal processing, because you're activating the receptor directly instead of going through antigen presentation and processing. So they think that these drugs can actually bond right into the T cell receptor, and it requires that these T cells are actually pre-activated. And I didn't realize that you can measure T cells in somebody's blood for years after they've had a drug reaction and show that the T cells are still there to react to that drug for up to 10 years. You can measure these reactive T cell clones that are still present after that long a time from the initial reaction. So then if you look at cross reactions, this is another question, is this why these people are reacting to multiple drugs? Could it be just a cross reaction from a previous drug? So there's two things that go into cross reactivity. One is the structural similarity, and the other is the precursor frequency of these specific T or B cells. So in patients, again, with these severe drug hypersensitivity reactions, you can actually pull out of their blood T cells that are reactive to that drug immediately, and they don't go through any other system. And they can be detectable literally for years after the index event at 1 in 2,000 to 1 in 10,000 T cells.
Detected in what manner? How would you detect T cells?
You put these in a T cell stimulation assay, and you put the drug in that system.
Just a thymidine increase.
Correct. Yeah. And you can just show expansion of these T cells in direct stimulation of the drug itself. So if you look at the structural considerations, if you look at drugs that differ by a hydroxyl group, they're much more cross-reactive than drugs that differ by a side chain. So the T cell clones reactive to amoxicillin will see ampicillin very easily because there's only a difference of a hydroxyl group, but they won't react to PENG or piperacillin because they're a side chain difference. So the structural phenomena there basically recommend what they consider a steric propensity for these drugs to react. And only a small fraction of these patients will cross-react with penicillin G or piperacillin, and they don't react to any of the other penicillins, basically, other than amoxicillin and ampicillin are sort of among them each other. And none of the amoxicillin-specific T cells react to cephalosporins at all. So there's a 0% cross-reaction between ampicillin, amoxicillin, and cephalosporin. And the thought is if only a small fraction of drug-specific T cells cross-react, you're not going to see a reaction until later on when that cell population can clonally expand. So there may be a small number of cells that are sensitized, but it takes longer for these to react because there's not enough of the sensitized T cells. Mike?
So it just seems to me we should have this type of test available to check people.
It'd be nice. And, you know, the number of different tests that they have, there's actually hundreds of different drug allergy tests that you can buy. And
they're not validated.
None of them are valid. And even the penicillin ones, which give you the highest reliability, they're 75%. And again, it's a situation is the drug itself, by itself, may not be enough of a stimulus until you take one of these pre-sensitized T cells, bang on it with a CMV infection, and then give the drug. And that may be the series of events that we see.
Have they done the same kind of thing with the sulfonamides? You know, popular belief that sulfa drugs cross-react with antihypertensives and with Celebrex and that. Is there? I take it it's this multiple drug sensitivity and not a true reactivity.
Yeah, the sulfa groups, the people who react to the sulfa groups, is one particular metabolic product of the sulfa that actually causes all the reactivity pretty much. And you have to have a SO2 and a NH2 bond, and that has to be on the molecule to allow that to occur. So essentially the sulfa drugs they're mostly this T-cell mediated stuff instead of the IgE things. So they think that this explains that specifically, as a matter of fact. Why the sulfa drugs are so unique is because they directly get into the T-cell receptors better than pretty much any other drug.
Well, is it real, though? Do they really, in real life, I can see this in the lab, but, is there really good evidence that people had sulfonamide reactions, had more problems with Celebrex or Vioxx?
No.
Clinically, they don't.
No, and if you look at these people that sensitize, the data is if you have an IgE-based reaction for your first reaction, all your subsequent sensitivities will be IgE-based. Very few people will actually cross over from one mechanism to another. So the people that are T-cell-based reactions, all their subsequent reactions will basically be further T-cell reactions. And that was a very unique feature of this group, is that they don't have multiple mechanisms of sensitivity. They have one, and they sort of follow that all the way through all their drug challenges in the future. So if you look at this and you summarize this group, these people, these two groups, MDIS or MDAS, are used to describe different side effects associated with different drugs. And they include both allergic, immune-mediated reactions of types 1, 2, 3, and 4, plus pseudoallergic reactions like the non-steroidals and the contrast reactions. If you look at Pickler's data, and his article is probably the best about mechanism, about this immunity interaction data that his lab has done. About 10% of patients with drug hypersensitivity will have multiple drugs that they're allergic to. And the other 90% of people who have a history of drug allergy are not going to have this multiple drug syndrome. If you look at Sciavino's group in Italy, he thinks it's 6%. So 6 to 10% of these people are maybe polydrug allergic. The drug reactions are almost always type specific. So those who develop a T-cell reaction will have a second and a third T-cell reaction, and those that develop IgE will continue to have IgE-based reactions. And if you look at these, the reasons for the drug hypersensitivity reactions is really not well known. So the theory is, why do these occur? One is a deficient tolerance mechanism, and that these people just can't process these small chemicals without binding them up to something that stimulates their T cells. And the second is this immune reaction through the pharmacologic immune receptors. And the most significant risk factor for this is previous drug allergy reactions, and not anything else about hay fever or other immune systems. It's actually previous drug reactions. When they look, they can't find any defects in the regulatory T cells. And if you look at these CD4 cells, they show signs of pre-activated state, which just is present for years, which may be why these people can have these reactions so quickly, because the cells are already primed up and ready to respond. And then they can go from one drug to another. So if you're going to try and read anything else about this syndrome, if you want to read about it not existing, Macy is the article to read, because he doesn't really think this exists. And if you want to read about someone who thinks it actually exists, you can read Pickler's data, because he thinks that this is a real disease with a small representation of the medical population. But he says it is real, and it's probably a lot smaller group than we think. And then the rest of these guys are, most of the controls are, most of the studies that they did with the challenges. Pasquale is the guy who did the drug skin rashes that were exfoliative and toxic epidermal necrolysis, and Stevens-Johnson. Raymond is the guy who showed that most of these people, when you oral challenge them, their oral challenges are negative. So when you do 1,800 challenges and you only have 20 that are positive, you sort of start wondering, is this real or not?
Those were blinded challenges.
Yeah. And then there's a neat up-to-date review of this in 2013. They reviewed drug allergies and drug allergy testing very well. It's a 25-page review and up-to-date. So if you want to skip over everything else and just pull that one up, you can get pretty much a summary of most of this right out of that one article.
Did they reach a conclusion? Because those are usually very well done.
They reached the conclusion that if this is real, it's a very small subset of patients, and it's not, in general, a thing that we need to be concerned about. but they also recommend that, and Rebecca Gruchala, she has 2 or 3 articles in this, and her comment is that nobody's challenging to drugs anymore. Everybody's just writing them off as they're allergic, and she says that we're using really expensive drugs and we're getting into a lot of trouble because we're not challenging these people with these bogus histories and using the drugs that we should be using.
There's a question from the outside here. In the Schiavono study, what was the challenge process? Was it a one-time dose or 5 to 10 days of treatment? If the majority passed, was it one-time dose?
It was a one-time dose, and then they followed the people for 7 days to see if they reacted after the challenge in the laboratory. They had them come back 7 days later and describe any reactions that they had, and if they had a reaction, they had them come back immediately.
You know, I think the hard part about challenging is if you take that population of patients that they might be a little bit more anxious, a little bit more psych, you know, it's tricky to do a challenge because all of a sudden they start telling you their throat's swelling or whatever, but there's no objective symptoms. But then you sort of got to believe the patient. I mean, that's probably part of the reason. I mean, do you want to spend your afternoon dealing with someone that's a little bit fringy?
My answer to that question is no. I don't want to.
Exactly. So that's why we don't do challenges, right?
But the thing is, what happens with these people, if you look at what happens when we don't challenge them, their cost of therapy goes up astronomically.
Right, and it's probably making it worse because then they're getting all these other drugs.
Right. So when you're giving somebody IV vancomycin because they tell you they're allergic to Keflex, I'm not sure we've done them a big service.
Exactly. So I don't, what's the answer? I mean, maybe they all need to go to like Steve Tillis where he can do the vocal cord stuff while they're.
I think the answer is you have to take a really good history on these people, and I think most doctors, they hear allergy and that's the end of their history. They don't ask about the reaction. And every one of these articles is the same. You need a really, really accurate history because you need to define the mechanism of reaction and the reaction itself. And then if they don't have a discriminative reaction where you're likely to kill them on challenge, or they don't have anaphylaxis, they recommend that you challenge everybody. And again, so few of these challenges are positive, Mary. I think you can probably be reading a book while they're doing their challenge in your office. I don't think you have to sit there and watch them. And the people who complain of, their throat feels funny and all that, I sit there with my oximeter and go spirogram them a couple times and say, you don't have any data. And then they'll finally calm down, most of them. It's like, well, I guess it went away. But the sad thing is that we can do this for the clinicians, but nobody wants it anymore. They just switch drugs. And I think that's the overwhelming concern is that these people just frustrate everybody that takes care of them, so they get these incredible drug cocktails that no one else would get.
There's some more questions. I'll get some outside questions.
My question is more to all of the allergists. Has anyone done placebo challenges with the actual drug?
All the studies that were published, they all did placebo challenges.
But I mean in practice.
I've done a couple of placebo.
Okay.
Yeah, because you get, the patients come in and a little bit like, what Mary said, you kind of think they're going to have something. So I tell them that we're going to do multiple challenges and that one of them will be placebo.
Dr. Condier was talking about that at the Quad AI, and he does it a lot and really advocates it.
He does the most.
And finds it very useful for the patients. And
But the
he gets
patients-
consent that, he's doing a placebo trial.
They can also call back, like you do the successful challenge and nothing happens, and then they'll call back 2 days later saying that they felt
And if you go
something,
ahead and
and
give them that-
you don't really think that really is anything. But once they've kind of said that to you, it's kind of tough.
You give them that drug and then there's a lawsuit.
Well, basically what I do, and this is just my own personal thing, is if you have anything, you come back, we'll work you in and we'll see you that day. So I think if you're going to challenge them, you're obviously not going to keep them more than a day unless they're in the hospital. But you have to give them the option to come back and show you. So if they don't ever come back, and I get into this with a patient said they're allergic to their flu vaccine. So again, she describes all these reactions, and I said, you need to come back and show me. And she would never come back, so I have to assume she didn't have a reaction to show after we challenged her. Matt.
We definitely see a lot of these patients who were hospitalized for some bad infectious or inflammatory disease, got a bunch of rashes, 10 drugs are on their list. And maybe it is through this PI mechanism, and we can then prove that they tolerate them all, we challenge them, and so forth. my question is it relevant that they had those? You know, because they're unlikely to be hospitalized with the same infection again, but you're saying that maybe in the setting of an infection they would react again. Does it matter?
I think that it's infection specific, not just any infection. And bacterial infections don't seem to stimulate. It's usually viral infections that do. And number two, just the fact that they're in the hospital is a risk factor for an adverse drug reaction because usually there's a lot going on.
So if we can show that they tolerate it when they're in good health, does it matter, even if that mechanism is valid, that it happened?
Again, I think you're asking a really important question is how do we amend their record? Do we say this person's not allergic because we challenged them when they were totally healthy and nothing happened? Knowing full well.
The trouble with that is you're likely, many of these are antibiotic.
Correct.
You can give an antibiotic because they're sick with some infection, often viral that they didn't need the antibiotic for, so you're setting up a bad situation.
Correct.
Here's an outside question that kind of bears on that. Our patients with chronic autoimmune illness have increased ADR during flares of their autoimmune disease. So I guess another way of saying if your immune system is revved up with an autoimmune process, and this mechanism is true, is this a risk or is there data for that?
Well, there's the one study that addressed that, and they said that 18 of the 20 patients addressed autoimmune urticaria, and then that group was in the MDIS category were significantly higher represented. So anecdotally, I think the answer would be yes. I don't think that there's been a study that directly...
I read that study the other way to mean that what people blamed on drugs was just recurrences of chronic autoimmune urticaria. The drug had nothing to do with it.
Correct.
It's just manifesting hives randomly.
That's what I tried to say, but obviously it came out backwards. But basically, I think the data would suggest that no, but there's not really good data to say that.
We've got another question, unless we've lost him here.
Matt.
So that group who sort of has multiple reactions while sick, they're often anxious but not crazy. And I found we can help them. Same with those with urticaria. You can kind of prove that's what they have and treat that. There's another group that I find very difficult, those who sort of have multiple intolerances. They get nauseous, lightheaded, fatigue with every drug. I wonder, I don't know if you look into this, but are there any studies looking as to whether certain of those individuals, again, who have sort of adverse effects with everything, have impaired metabolism of drugs or sort of common
That's
side
literally
effects?
one of the other postulated mechanisms is they metabolize these drugs differently, and the metabolites are what give them the problem. But all of the studies that are done, most of the patients that have negative, quote, studies have symptoms that you just described. They have nausea, they have upset stomach, they have diarrhea, nothing that can be tracked back to the mechanism of the drug, its use, or a typical immune response. So essentially, those people have a higher level of overall reactivity, but not specific to the drug. So I think you have to sort that out. So the placebo, I mean, I always am amazed how impressive placebo responses are. And these people, you give them anything, and they're likely to have reaction just because of the way they're set up.
Here's a question from Art. What about penicillin and cephalosporins with similar side chains? Do they have a higher rate? I presume he's saying of coincidental reactions, and doesn't amox and cephalexin, I presume, have similar side chains?
Well, if you look at their data, when they did the challenge data, the amoxicillin and ampicillin are aminopenicillins, and they're the only two that are in that group of penicillins, and they didn't cross-react with any cephalosporins at all.
Does Sullivan, I remember Sullivan years ago when he was in this field, and he had some crazy data, like 50% of people with penicillin allergy were cephalosporin reactors, which is never been true. Probably the rate is closer to zero. But he had a lot of theories about this. Does his name pop up in the literature anymore, Tim Sullivan?
Pretty much no. He's in the older literature, but sort of Rebecca Grushala sort of picked up where he left off. And now most of this is, again, if you're looking at existence of the syndrome, it's mostly Macy. And it's just kind of going through this Kaiser data. And then if you look at the actually mechanisms of reaction, that's mostly Rebecca Grushala, and she's sort of taken up where Tim left off. So he had one article after 2007 that was sort of an editorial, but there's really not any more science that I found from him involving these groups. But the recommendation when we allergy test drugs is that we don't test anything but penicillins and cephalosporins, because they said that the breakdown products of these drugs are much more important than the drugs themselves out of the bottle. And I always thought that if you left your penicillin hanging around for a long time, it would break down, but it doesn't break down into any useful pieces. So there's no benefit to old drugs versus new drugs. And without the pre-pen, our penicillin testing is pretty miserable, but with pre-pen, they think it's a 97%, a true negative is 90% reflective of a true negative. So there's a 3% miss there. None of the other drug testing is better than 75% of any other drug, except for penicillin.
Brett just wrote in a comment here, nothing, Mike, you want to read it? I think these patients are more difficult, require placebo to sort out the quote, throat feels funny, etc. Now, obviously, if you don't do placebo challenges, you have absolutely no idea what you're accomplishing.
Right. But you have to have a lot of time to work these people up. I mean, you couldn't do it in your office without totally destroying your office flow for the day. Because they have all these reactions that they're going to want you to evaluate. But I think that's the only way to evaluate these people.
Send them all to Gary.
What's that? I was just going to say, well, I don't mind because with the new code, you can charge over $200 for the hour. They have to be there an hour and 5 minutes. That might be a motivator to do it more often. In the past, you weren't compensated for it. Now you are. And maybe the reason they're doing that is trying to work these people up. And so they get on cheaper antibiotics and less.
Flex instead of Vanco. I mean, that's a pretty scary thought. These people that aren't even sick get vancomycin for something they shouldn't get an antibiotic for at all.
Well, a big HMO situation is motivated to do it for saving money.
Well, it was sort of interesting that the Kaiser data is so damning of this as an entity in and of itself. I mean, he really thinks this is mostly hype, and there's not really very much to it. But then when you ask him about the 1 or 2% that are true, he says, yeah, they're real, but he says that 98% of these people it's factitious.
You know, the one thing you said that resonated with me, that there could be some credibility in that T-cell mechanism, we all do, except if you've got EB virus infection and you give amoxicillin, people get rashes. You know, no one actually challenges that. That's clinically true. So there's some real immunologic mechanism, and I guess it lends some credibility to that argument.
With mass spectrometry and X-ray crystallography, they've actually been able to show that these antibiotic molecules can align themselves in the MHC receptor and the T-cell receptor just like a normal presentation through the immune processing pathway. So they really think that this is the actual mechanism that it occurs. The fact that you can have activated T cells to a drug allergy 10 years after you've had the drug, and that freaked me out. I couldn't believe that data. But it's true. So you give them this drug again, and they're already primed up. So once these people have had an adverse reaction, they're set up to have adverse reactions to a whole bunch of other drugs very quickly because these T cells are already primed up and floating around in their system. So that, again, there's a subgroup of people that this is probably a real entity, and then the bulk of them, I don't think it is.
Okay, I mean, how clinically relevant is that? It's only if they're sick with that same virus again that you would worry about a reaction, or?
I think that's the $64,000 question, Matt. So when is it relevant? So again, you got to take the whole thing into context. I think if you challenge these people, we don't have to challenge them when they're healthy. We can challenge them when they're sick.
I mean, I did that several times in residency, and generally they do fine. That's my experience. But
and I think the statistics would support you that about 98% of the time they're going to do fine. Yeah. The 2%, I don't know whether you can sort them out by history or whether there's some other laboratory evaluation that will come along. But as Gary said, they're starting to code for this as a real entity. So maybe they'll allow us to do some of the tests. Maybe the Center for Medicare and Medicaid Services will approve one of these tests, and then we'll get some usefulness out of that. I'm not optimistic, but it may happen.
This would be a good service to have here at the U, Drew.
We challenge people almost every day.
We're doing a lot of it, actually.
Yeah.
And I think we've helped a lot of people with this. And again, most of them fall into that category of either chronic urticaria or were in the hospital sick and came out with 10 drug allergies. Those people you can really help. It's those ones who just go home and they feel sick with every drug.
But I think the number of people that we're actually doing that to is way lower than we should be doing that to. So you guys should be a lot busier. You should be doing 10 drug challenges a day instead of one.
We can do it IV on kind of an inpatient basis. And the other thing about these reactions, as Stephen and Sean said, no one's getting
be challenged if that's the case, but those are very rare.
You hope that
And worst case scenario, they get a maculopapular rash afterwards, and that's a small minority in our experience. We've had a few this year that have developed it, but you treat through it. And, I don't think there's a lot of downside to challenging these folks.
there isn't, as long as you're careful and you're in the right setting. I think that's the overwhelming message, is if you have the facilities to challenge these people, you do it. See, we have one infectious disease doctor in my clinic, and if penicillin is the drug of choice for disease, he doesn't care what their history is. I get called in the middle of the night to come in and desensitize them. Now, whether they really have a history of allergy, usually the histories are sort of sparse, but you got to do it because you don't really have a choice. And, we'll put them in the ICU, and the nurses are sitting there yelling at you for the first 20 doses, and they're like, okay, now we're not mad at you anymore. But, I've never had somebody crash through a penicillin desensitization, so I don't know whether I've been incredibly lucky or whether it's that good, but I've never had a crash.
It's that good.
I mean, it's probably a combination. Most of those people weren't allergic, but it is that good for those who are.
But again, the data would suggest that the only test that we have that's any utility at all is penicillin.
Right.
And everything else is just a
That's
waste.
the sort of true allergy.
Right.
Coming back to the hyped up immune system and reaction, and other times not, like Matt was talking about. I've seen that with the sulfa and AIDS patients. They have a high reactivity rate. On the other hand, I've challenged probably 10 of them in my office after apparently they're over their hyped up immune reactivity. They have no problems, and they go on and take it prophylactically. So it's that same kind of thing. So it's a non-specific.
And of all the people
it is specific.
Of all the people that I personally have put on trimethoprim sulfa with their pneumocystis, I've probably desensitized 20 people, and not one of them's reacted. So again, I don't know whether I'm just really lucky or whether this history is just not as accurate as we think, and these people really are not reactive. But the HIV virus is the one that whacks out your immune response worse than all the other ones. And that's why they seem to be predisposed to these horrible skin reactions. And the HIV data, that's overwhelmingly more of those reactions per person than any other group, is the HIV-infected people. And I don't know whether it's the sulfa plus HIV, that's a bad combination, or whether there's something else unique about that viral stimulation.
You would think. So we recognize that reaction pattern early in the AIDS epidemic. You would have thought those people had virtually no T cells to be responding to anything, let alone haptons of drugs. So it seems counterintuitive.
They have these overwhelming reactions. Yeah, the mechanism doesn't inherently make sense, except the statistics are overwhelming. It's just, I don't know where they react if they have no T cells. You're right, but
They're probably different T cells. They may be CD4 deplete, but I think certainly the skin reactions are often CD8.
CD8, maybe that. Well, this is an excellent presentation. I thought everybody with this was crazy, but maybe there's
2% of people aren't crazy. Yeah. Did you have a question?
All right, so remember tomorrow night, everybody's welcome.
Okay. So we will send you a lot more business.
I find it very sad.
You feel good when you say you have this drug.